Yes.
Dr. Dempsey, I just want to ask you a little more about hepatitis. Sally, could we have Dr. Dempsey's statement on screen? WITN 5560001, and go to page 15, first of all. Now, at the bottom of the page, you say this in paragraph 21.1, commercial factor concentrates have been associated with an outbreak of hepatitis B in the early mid-1970s. By 1980, hepatitis B testing of donors and more careful donor selection had improved the safety profile of commercial concentrates. And then you say you weren't aware of any difference between commercial concentrate and NHS concentrate with regard to any background concerns about the transmission of non-A, non-B hepatitis. Just sticking first of all with hepatitis B, would it be right to understand that as at 1980, you were aware that hepatitis B could be a very serious condition?
Oh yes, very much so.
And then, as I understand your evidence before the break, the basis for your view that there was an improved safety profile of commercial concentrates in relation to hepatitis B were the assurances or information you'd been provided with by pharmaceutical reps?
Well, in large measure, but I think there was feed through also from the UK HCDO about this, and I got the impression from reading minutes that as far as they were concerned, that things had improved considerably.
Do you recall what your understanding was of the sensitivity of the hepatitis B tests and the different types of hepatitis B tests that were available by 1980?
Well, I think there had been general, I can't remember exactly, but I think there had been a growing improvement. But I wasn't conscious that there was a major problem with the residuum of hepatitis B infection by 1980. I mean, obviously the patients who had been infected in the past were still there, but I wasn't conscious that there was still a significant number of new cases coming through. I mean, I was conscious that screening might not be 100% effective at screening out hepatitis B, but I wasn't aware that there were a continuing stream of new cases.
Now,
rather than the opposite.
Now, there obviously wasn't testing for non-A, non-B hepatitis at this point in time, but did the assurance you've received about more careful donor selection procedures also reassure you that there was a reduced risk of non-A, non-B hepatitis from the use of concentrates?
I would have thought that there was still a risk of non-A, non-B hepatitis with commercial concentrates. But then I was aware there was a risk of non-A, non-B hepatitis with NHS concentrates as well. Obviously, as you say, there was no testing for non-A, non-B hepatitis. And I mean, what more can one do except screen the donors and exclude certain groups and hope that improves the profile of your panel of donors and the plasma that comes to be fractionated as a result. Excluding non-A, non-B would have been a difficult task without having any criteria that you could go by.
Now, if one leaves aside the relative risks of transmission of non-A, non-B hepatitis from commercial or NHS concentrates, if one takes the class of concentrates as a whole and compares that to cryoprecipitate, did you understand that there was a greater risk of transmission of non-A, non-B hepatitis through the use of concentrates than cryoprecipitate because the recipient would be exposed to vastly more donations?
Oh, yes, I realize that, at least in the short term, the risks with cryoprecipitate were very much less. But obviously, the more cryoprecipitate you got over a number of months, years, the greater exposure to an increasing number of donations that went into that cryoprecipitate, your risk of developing or contracting non-A and non-B hepatitis would increase over time. So cryoprecipitate wasn't without risk also, but reduced risk certainly in the short term, very much reduced risk.
And for the cohort of patients whom you were treating with concentrates, the moderately affected patients, those were, as I understand your evidence, relatively infrequent attenders. You were not dealing with the severely affected patients who, if they had been treated with cryoprecipitate, would, as you say, be receiving it on a regular basis.
They weren't coming very regularly, no.
And then can we go back? Sorry.
Sorry, I keep saying, adding to the sentences. This group of moderate haemophilia patients, yes.
And then can we go back to your statement, please? So WITN 5560001. And could we go to bottom of page 16 to start with? So you say there in paragraph 23.2, in relation to non-A, non-B hepatitis, I understood that occasional cases of jaundice have been noted in relation to the administration of factor concentrate. And then if we go to the top of the next page, 23.3, a small number of cases of cirrhosis have been documented. Subtle variations in liver function tests were also noted in some patients. The problem was of concern and was actively monitored, but not thought sufficiently serious to merit withdrawal of the only really effective treatment for severe/moderate haemophilia, which carried a high risk of death and crippling from uncontrolled hemorrhage. And then if we could just go down a little further so we can see paragraph 23.5. You say there, non-A, non-B hepatitis, I appreciated, could cause chronic liver disease and was transmissible by blood products, but in most cases was a self-limiting condition without long-term ill effects. Now, if we can keep that up on screen as it is, please, Sally. Can I ask you, first of all, about what you say in paragraph 23.3, where you say the problem was of concern and was actively monitored? What kind of active monitoring was undertaken for your cohort of patients?
Well, just regular liver function tests, repeated when the patients were routinely reviewed. I'm not saying that I had any cases that I could definitely say were non-A, non-B hepatitis, but it was the case that patients with haemophilia were monitored as a routine with the repeat liver function tests, and people looked at them and wondered about them, but provided they weren't very elevated, then people didn't at times know what to make of them.
And then,
Sorry.
Carry on.
No, it was just an add-on to the sentence. There wasn't anything major in it.
And then paragraph 23.5, you talk about non-A, non-B hepatitis in most cases being a self-limiting condition without long-term ill effects. What was the evidential or factual basis for that, your understanding of non-A, non-B hepatitis in those terms?
Well, that was really around 1980, and we were on a learning curve from 1980 on. The feeling that it wasn't a major concern was the general feeling among I think haemophilia specialists and liver specialists generally. I can't quote chapter and verse on it, but I think that was the general feeling at that time. But that's not to say that some patients didn't have at that time evidence of chronic liver disease, and certainly there were patients like that in the adult haemophilia service in the Royal Victoria Hospital.
Wasn't the risk of chronic liver disease, albeit that might not be in most cases. But wasn't that risk in itself a sufficient justification for preferring cryoprecipitate to concentrates for the bulk of moderately affected children?
Well, it would be if you had complete faith in cryoprecipitate. But my faith in cryoprecipitate had been severely damaged by the case I explained to you earlier. I mean, when we come to look at joint bleeds, the moderate patient may not bleed as frequently as a severe patient, but the bleed, when it happens, can be just as severe as any bleed in a severe patient, and it must be adequately controlled. If you lose control of joint bleeds, the risk is that a joint will start deteriorating in as short a space of time as a couple of months. If you get bleeding and rebleeding and a cycle of rebleeding, you're looking at degeneration starting inside a space of 2 to 3 months. And it's absolutely critical that effective control of joint bleeds is affected, because otherwise you're going to end up with the patient with the crippling arthritis, that was so typical of haemophilia patients in the past. So if one has faith in cryoprecipitate, then by all means it's the treatment of choice. But I think if you feel that it's probably not, or if you're worried that it's not going to achieve what you set out to achieve, then you've got to think again, and you've got to look at the possibility of cryoprecipitate treatment as an alternative. So I think that really summarises what I want to say.
And if we then just look at, back up on the screen, paragraph 23.3, you say non-A, non-B hepatitis not thought sufficiently serious to merit withdrawal of the only really effective treatment for severe/moderate haemophilia, which carried a high risk of death and crippling from uncontrolled hemorrhage. Now, we leave aside severe haemophilia because you weren't treating patients with severe haemophilia at that time. Was it really your view that concentrates were the only really effective treatment for moderate haemophilia, whatever the nature of the bleed, whatever the frequency of the bleeding?
Well, I suppose that sentence would apply especially to severe haemophilia patients who are rebleeding on a regular basis. Moderate haemophilia, patients with factor levels of 2 to 5%, it depends really how frequently they bleed, and I suppose within that category you could get a degree of variation. Internal bleeding is always a problem, and internal bleeding especially can lead to pretty rapid death in the haemophilia patient, and to rely on cryoprecipitate in a situation like that, especially in a moderate patient or indeed a severe patient, is taking a major risk. As for joints, well, I suppose if you're happy to try the cryoprecipitate, but you look at the joint. If you're not happy with cryoprecipitate, you look at the joint you're managing, and you worry that it's not settling quickly enough, and you worry, is it really the cryoprecipitate is not controlling this hemorrhage, and maybe I should use concentrate here in case there's going to be damage, and maybe this joint has rebled very quickly, and maybe the cryoprecipitate that I was using hasn't sufficiently controlled this joint. And do I keep on with cryoprecipitate, or should I go on to concentrate? You're always going to have this conversation with yourself. If you have any degree of worry about the effectiveness of cryoprecipitate, if you're totally convinced that cryoprecipitate is the treatment of choice, then you're going to have faith in it, and you're going to be more reliant on it and less likely to worry about having to intervene with concentrate.
Because as I understand it, Dr. Dempsey, you essentially switched from what had been a policy of cryoprecipitates for all moderately affected patients, your predecessor's policy, which you inherited and continued for a while, to a policy of commercial concentrates for all moderately affected patients. Having regard to the risks of non-A, non-B hepatitis, do you think, looking back now, that a more nuanced approach might have been more appropriate, whereby you looked at each individual moderate patient and asked yourself whether in the first instance, given the reduced risk of non-A, non-B, cryoprecipitate was right for that child on that occasion?
Possibly, but you might have ended up in a situation where you were using cryoprecipitate sometimes and you were using concentrate sometimes. And if you're using concentrate at all, you'd be subjecting the child to the increased risk of the non-A, non-B hepatitis if you introduce the concentrate at all. So it would either have to be totally cryoprecipitate, I think. You couldn't have a mixture of cryoprecipitate and concentrate every time you worried about it. But I suppose a nuanced approach might be have been more appropriate. In retrospect, I wouldn't have used the concentrates at all, given what was likely or what was going to happen further down the road. And when I look back on it, I feel that the NHS product might have been a better modality of treatment to have employed back in 1981. And but there was still, as I say, a risk of non-A, non-B hepatitis from NHS product, so I wouldn't have escaped that. The possibility of inducing or seeing non-A, non-B hepatitis arise in patients if I used only NHS material.
Can I move to the awareness of AIDS? We've touched on it, obviously, because of your change of approach on seeing the advice from UK HCDO in June 1983. Do you recall how and when you began to understand that there were cases of AIDS being reported in haemophiliacs in the States and cases of blood transfusion transmitted AIDS?
Well, I think well, that was in 1982 or the latter part of 1982. I think I would have been aware of that then, yeah.
We know that in January 1983, Dr. Main, along with a number of others, not you, attended a meeting at the Excelsior Hotel at London Heathrow Airport with reps from Immuno, but also other reference centre directors and Professor Zuckerman and others. Was that, do you recall her ever discussing that with you or telling you anything about that meeting?
No, I can't say that I do. That's not to say that she didn't, but I can't recall that.
And do you recall having discussions with Dr. Main as this awareness of the risk of AIDS developed in the latter half of 1982 and through 1983?
Well, yes, I think there was a general discussion about AIDS in every gathering in the hospital is discussed at physicians' meetings in the Royal. It would have been discussed in the Children's Hospital among paediatricians. It was a general source of interest and discussion. It would have been discussed by my haematology colleagues, Professor Bridges and Elizabeth Main. Yes, it would have been.
You've referred in your statement from time to time to there not being, I think, evidence of a firm link at various stages. But more broadly, from late 1982 onwards, were you ever under any real doubt that AIDS was transmissible by blood or blood products?
Well, I was in no major doubt. I was in no major doubt because any alternative theory didn't really seem to hold water. So I suppose I was in no real doubt but the haemophilia community were not prepared to commit themselves totally and utterly to AIDS being, the idea of AIDS being related to transmission by blood products. And when I've referred to the possibility of a relationship, I'm really echoing the feelings of the UKHCDO, of which I was aware.
Now, you made the change from the commercial concentrates to the SNBTS product after seeing that advice from UKHCDO in June 1983. And as I understand your statement, you then continued using the SNBTS product, and then in the autumn of 1984, you became aware that there were reports from Edinburgh of the SNBTS product having, or patients in Edinburgh treated with the SNBTS product having been infected with HTLV3. Can you remember how you, or from whom you heard about what had happened in Edinburgh?
I'm not quite sure. It either came through Dr. Main or perhaps through the blood bank. That information would have come through from the PFC, who would have been aware that there was a contaminated batch of SNBTS factor 8, and they would have been alerting users and withdrawing batches. Yeah, no, it would probably have come through from the PFC to the blood bank, and I would probably have acquired the information there in late October, probably the beginning of November.
And your statement suggests that you then contemplated stopping SNBTS product and reverting to the earlier policy of cryoprecipitate. Is that right?
That's right. I wouldn't have given the SNBTS product after the beginning of November, when I found out that the Edinburgh cohort had been discerned.
And then your statement says, in fact, the heat-treated SNBTS product then became available to you in early December 1984. That's your recollection?
Yes, oh yes, that's right, yes, definitely.
Did you, in 1983 or 1984, prior to the availability of the heat-treated product, did you ever offer your patients or their parents a return to cryoprecipitate as an option for them to consider?
My attitude was to the SNBTS factor 8. Over that period you describe, I retained faith in the safety of the blood supply from Northern Ireland and Scotland, which went into the concentrate. I very much regarded the problem with AIDS and its transmission as a problem around imported commercial concentrate. And at that time, I was very much, I had great faith in the Scottish product until I found that that faith had been misplaced. Now, of course, whenever I changed treatment, it was discussed with the parents at that time. The various changes that I've enumerated to you today in the factor 8 that was utilised was always introduced after discussion with the parents and after discussion around the alternatives with them. So I think they were on board with the use of SNBTS. But of course, the information you can provide patients with is the information you have, and you can't do any better than that.
After the end of 1984, as I understand your statement, you continued using the SNBTS heat-treated concentrates, which was, I think, NY, and until... until July 1987, when the next generation Scottish product, Z8, became available to you. Is that right?
That's right.
If we just look at your statement, WITN 5560001, and we go to page 21, please. So bottom of page 20, first of all. So just picking it up at the bottom of page 20, you say, it's paragraph 32.1 of your statement, Z8 treatment commenced in this centre in July 1987. This product appeared to have an improved safety profile and was substituted for NY. The centre, and we'll go to the top of the next page, stopped using NY after July 1987. And then you explain that NY was then withdrawn from use. And then you refer in paragraphs 32.3 to 32.5 to an instance in which a patient was treated mistakenly with NY after that date because those vials had remained in stock when they should have been returned. Leaving aside the circumstance of that patient who you've said did not seroconvert to hepatitis C, it would be right then to understand that up until July 1987, your patients were being treated with a Scottish product which was effective in terms of preventing the transmission of AIDS, but which became known was not effective at preventing the transmission of non-A, non-B hepatitis. Do you recall when you became aware that NY could still transmit non-A, non-B hepatitis? Was that always your understanding?
Oh, that was always my understanding, yeah. I think from the very beginning, we knew that the heat treatment wouldn't necessarily render the product sterile from a non-A, non-B hepatitis point of view.
Now, BPL, but at this time, was producing a product 8Y, which was more effective than NY in terms of inactivation of non-A, non-B hepatitis. Do you recall being aware of that?
No, I was never aware of that. I was never aware of that. It wasn't available to me, and I didn't use it. If it had been available and it had realised that it held out the prospect of not transmitting non-A, non-B hepatitis, I would have used it, of course, but I didn't realise it existed. I wasn't aware of it.
I don't know whether you'll be able to answer this, Dr. Dempsey, but do you know from any subsequent conversations you may have had with her whether Dr. Main was aware of 8Y and its improved safety profile?
No, I don't know. I don't know if she was aware of it, no. I mean, it wasn't on general release throughout the UK. It was restricted, as far as I know, to England and Wales, the catchment area for Elstree and BPL. I didn't think it was available through the Scottish link.
I wonder if you could just help me with one thing. As I understood your earlier evidence, what was stocking the blood bank for the treatment of those who had haemophilia was the responsibility of Dr. Main to choose. And you chose your product for what was in the blood bank. So how, in your last answer, or last set of answers, you said that if you'd been aware that 8Y held out the prospect of not transmitting hepatitis, you would have used it. How would you have got hold of it if it hadn't been in the blood bank?
Well, if I knew it existed and they were making it in BPL, I'd have phoned BPL and asked for it.
And you'd have been able to do that?
Well, I would have phoned them, and I would have spoken to them, and I would have found out if there was a possibility that I could have it. And if I could have it, I'd have liaised with the blood bank and Dr. Main.
You?
Now, I want to move to ask you now, Dr. Dempsey, about the kind of information that was given by you to patients or their parents about the risks of viral transmission in the 1980s. If we go to your statement again, WYTN 5560001, page 19, please, Sally. We look at the bottom of the page, paragraph 29.1, you say initially advice about infective risk and blood products in the early 1980s centred around the possibility of jaundice, which in most individuals was thought to be self-limiting, although occasional patients were noted to have developed cirrhosis. Now, in the early 80s, what information do you think you gave patients and their parents about risks of hepatitis?
Well, any patient starting treatment for haemophilia had a very lengthy conversation about the disease, leading on to a very lengthy conversation about the available treatments and the side effects of those various treatments. And hepatitis would have featured very strongly or very majorly in that discussion, very prominently in that discussion. And I would have said that there was a risk of jaundice. A minority of patients became jaundiced. A minority of patients could develop evidence of liver disease, which could be serious and progressive. But most patients didn't experience these side effects. That would have applied to cryoprecipitate in my discussions about cryoprecipitate, as it did in my discussions about concentrate, if I was employing concentrate. So that was what I said to patients in the early 80s. In terms of what could possibly happen around treatment with cryoprecipitate or concentrate.
Would those conversations have taken place only in terms of that level of discussion with a new patient, or was that a conversation you had every time that parents brought a boy to the ward?
Oh, I wouldn't have had it every time. I would have picked up on the patients I took responsibility for back in 1980 when I came into post, and I would have talked to each of the parents then about the problems that might be associated with the treatment they were having. But I wouldn't have had a conversation with them every time they came. I would assume that once I had the conversation with them, I wouldn't necessarily have a lengthy conversation again with them unless I was changing the treatment, or I proposed to change the treatment, or I gave them the option of changing the treatment.
When you were changing your moderately affected patients from cryoprecipitate to commercial concentrates in that period, 1981 through to the middle of 1983, did you, as far as you can recall, explain to patients the significance of pool sizes or different donor profiles, or the fact that there was a significantly greater risk of transmission of non-A, non-B hepatitis with concentrates than there was with cryoprecipitate?
Oh, yes. I mean, I spoke to them about the potential risks associated with concentrate as opposed to cryoprecipitate. I don't think I went into detail or touched on pool sizes when I was talking to them, or about donor panels. I didn't discuss that level, go to that level of discussion with them, but I certainly discussed the relative risks of cryoprecipitate and concentrate.
And as well as referencing jaundice, would you have, do you think, mentioned cirrhosis or the possibility of further significant liver disease or even cancer?
I spoke to them about severe liver disease, yes. I did say the proportion of people had severe liver disease. That would mean cirrhosis, basically, which could be progressive. I don't know whether I mentioned cancer to them as such.
And would these conversations, or at least the fact that they'd taken place and that there'd been a discussion about the risks and benefits of treatment, would those be recorded in the patient's notes?
I think they would have been recorded in the patient's notes, that I had spoken to them about concentrate, about the side effects of treatment. Maybe I wouldn't have enumerated each side effect that I'd gone over with them, but I would have made a note that I had discussed the situation with them.
And then from late 82, early 83, with AIDS on the horizon, but you continuing to use commercial concentrates until the middle of 1983, what do you, as far as you can recall, did you say to patients about the risk of AIDS, if anything?
Well, I first started to talk to them about it, I suppose, in mid-83. When I took the firm decision that I would have to change from the commercial concentrate to the NHS concentrate, and I would have said to them then that there were concerns, there were worries about the commercial concentrate and a possible link to AIDS. I didn't say that there was a definite link and you were likely to get it. I didn't want to cause that much fear and concern. AIDS was being talked about more and more in the press, and whether I had raised the subject in June 1983, it was going to be raised with me by parents undoubtedly in the coming months. And when I say I spoke to them in June 83 and talked to them about the risks of what I regard as a causative factor commercial concentrate, and suggested that we should move to a safer product, I went into the detail about AIDS. And from there on, there was continuing conversation about AIDS through to the end of 1984. But as I say, I continued to retain confidence in the Scottish product with relation to AIDS. Confidence that was ultimately misplaced, but nonetheless, that's the position that I did take with parents.
And yes, you say in your statement, by mid-1983, you saw the possible risk of HIV infection as minimal at that time because you were no longer using the commercial concentrates, and parents were advised accordingly. So it would be right to understand, would it, that the parents of children being treated with the SNBTS concentrate would understand that was safe in relation to AIDS because that was your view?
Well, yes, it would be, unless they got an alternative view from someone else. That would be the view that I gave them at that time. Because, as I said before, I very much regarded the AIDS problem as being related to commercial concentrate.
Now, just want to ask you a little about the arrangements that were made for testing your patients for HTLV3 HIV. Your statement says that testing began in March 1985. Can you recall whether all the patients, 12, 14, however many of them there were approximately, whether they were all asked to come in the spring of 1985 for testing, or whether they were tested the next time they came in?
No, they were all asked to come up individually over a short period of time, see me, talk to me, have a blood sample taken for testing. And
did you explain what the purpose of the test was?
Very much so, yes. I did explain what we were doing. Yeah, why we had to do it, yes.
Now, as I understand your evidence, your written statement, none of the patients tested through these arrangements in 1985 were positive for HTLV3. Is that right?
That is right.
Do you know whether there were patients who by that time had transferred to the adult centre who were positive for HTLV3 and for whom the cause of their infection might have been the treatment that they received at the Children's Hospital?
I think it's very unlikely because if there were patients in that category, Dr. Main would have been sure to advise me of the fact.
The inquiry's seen evidence referring to a patient aged 14 in 1985 testing positive. The documentation refers to Dr. Main, not you. Do you recall Dr. Main telling you about any patients, teenage patients, testing positive for HTLV3?
No, she never mentioned that patient to me, and I had no details about that patient. I didn't previously know about that patient until the patient was mentioned during the inquiry sessions.
And if we just look at BHCT 0000861_003. This is a letter from December 1986 from Dr. Ritzer addressed to Dr. Main, Dr. Bridges and to you, and it refers to an apparent case of a patient seroconverting in 1986, potentially. Do you have any knowledge of that patient or of what's referred to here?
No, I don't know about that patient. No, I have no idea about that patient. I just wonder, was it the patient you just referred to a moment ago?
I don't know is the answer, I'm afraid.
I just wondered if that was the patient, but no, I have no knowledge about the matter.
We can take that down, thank you. Turn then to non-A, non-B hepatitis. Now, obviously, there was no ability to test for non-A, non-B hepatitis during the 1980s. Do you recall, however, having cases of patients who you suspected might have non-A, non-B hepatitis because of raised bilirubin or jaundice or ALT results?
There were no patients with jaundice apart from the patient you've mentioned a moment ago who received the NY treatment, 2 vials of it. That's the only patient who was jaundiced in my experience in my years in the Children's Hospital. There may have been patients with minor abnormalities of liver enzymes. There were never any major abnormalities of liver enzymes that I recall. So I was never very happy to label a person as non-A, non-B hepatitis during my time in the 80s, other than the patient we referred to a moment ago who had the jaundice raised liver function tests and who'd had the NY as opposed to the Z8.
In terms of then of testing for hepatitis C, once the test became available, your recollection in your statement was that began in 1992. How was it arranged? Was it a question of calling all the patients in as you did with HTLV3, or was it a question of waiting till the patient presented and then on that next occasion testing for hepatitis C?
No, they were called up individually. They were asked to come. Matters were discussed with them. A blood sample was taken with their permission, and the tests were batched and I think referred through Dr. Main, possibly to London initially, for the antibody testing. And I think it was possibly in 1991 as opposed to 1992. I've said 1992 in the statement. I think it may have been 1991. But I think that the tests were batched, and I think they were referred with some of hers, and I think it was possibly to London they were sent initially, if my memory serves me right.
And what's your recollection of how you communicated a positive test result to your patients or their parents?
I had counselled them on the matter, told them that I would write and give them the result. And when I got the result, if it was negative, I wrote to them and told them it was negative. And if I got a positive result, I wrote to them and I told them the result was positive, and I gave them an appointment to come up and see me within the next few days to talk about the situation.
There's an example of a case I wanted to ask you about, which is in the materials that were provided to you, Dr. Dempsey. If we can, this relates to a patient who is anonymous, so I'm not going to be referring to any identifying details. And it's really a general issue I want to explore with you. WITN 0007003 we can see here, so we can see it's addressed to you, Children's Hospital Laboratory, Dr. Dempsey. We can see there's reference to anti-HIV 1 and 2, hepatitis B surface antigen, and then anti-hepatitis C virus positive. And then we've got the date in the bottom left-hand corner, 23rd of January 1992. So, and then it appears the date of the specimen is the 14th of March 1991. First of all, are you able to assist us in understanding what appears to be the time period between the date of the specimen and the date of this test result?
Gosh, I have difficulty with that. As I say, I thought they'd been batched together, sent as a batch through Dr. Main, and we got the results back relatively quickly. Subsequently, when the testing was set up in the Children's Hospital, set up in the virology lab, repeat testing would have been done. That result, I would have thought, came about from repeat testing over and above the test that I've referred to and that was batched and I thought sent away. I can't explain why the date of the specimen here has been recorded as the 14th of the 3rd, 91. I just don't understand that.
In any event, we have... Sorry.
Unless the results were, unless the test was done in the local virology lab, the results were given to Dr. Main verbally and then communicated to me verbally for transmission to the parents. And this is a late report coming through that's been typed up. I just find it very difficult to explain that. It doesn't link in with my my memories of what happened.
In any event, we can see that the date of the test result there is said to be January 1992. If we could then look in relation to the same anonymous patient at WITN 0007005. This is a letter from you in relation to the patient dated May of 1995, 29th of May. And it says, as you know, we're now routinely testing patients' blood for evidence of exposure to hepatitis C. And we did mention to you some months ago we were taking a sample from the patient to test. Unfortunately, the results do show that the patient has been exposed to hepatitis C virus in the past and carries antibodies to this virus. This means that he is likely to be a carrier of the virus. Many patients who are treated with factor VIII in 1987 and prior to 1987 have been exposed to this particular virus and are positive for antibodies to it. Many patients who carry the virus are perfectly well and are totally unaware. In some patients, however, over a lengthy period of time, the virus can cause some evidence of liver damage. I appreciate this finding may be a shock to you. I'd be happy to talk to you both about the patient and the implications of this to him. And then you suggest a date. You say you don't think that the patient needs to be involved directly at this stage. No evidence of any problem with HIV or AIDS, and immunised against hepatitis B in the past. Are you able to assist us in understanding why, given there was the initial test result in January 1992, a communication is being sent to the patient's parents only in May 1995?
Yes, I remember looking at this in 1995. Patient was 15, and at that time, coming up to a time for referral to the adult unit. On checking through the chart, I couldn't find any reference to having seen or spoken to the parents about the positive test result that you've alluded to from 1992. I felt very strongly at the time, in 1995, that I had spoken to the parents, but I could find no documentation relating to that. And because I could find no documentation, I was forced to conclude that perhaps I hadn't, despite my strong feeling that I had communicated the result. So I set about going through the motions of contacting them again, talking to them again, and talking to them about test results again.
Okay.
So that it was thoroughly documented, and that I was convinced in my own mind that eventually I had done what I thought I had done in 1992, what I felt strongly I'd done in 1992, but can find no evidence of that in the chart.
So would you accept, as a matter of principle and general good practice, that if you got the test result of the kind we looked at in 1992, that should have been communicated to the patient or their parents at that time?
Oh, absolutely. And I did look at the other charts around this issue back in 1995 when I found this chart, and I was able to convince myself that I had written to all the other patients' parents, and I had talked to them. And I continued to wonder why on earth this patient apparently, his parents weren't contacted and talked to. I felt strongly at the time I had done it, but there was no evidence I had done it, and I had to assume I hadn't done it.
Can I ask you to look at a statement from Caroline Leonard of the Health and Social Care Trust, because she gives us, although she was not obviously the person involved, you were, she gives a slightly, or what might be said about slightly different explanation. It's WITN 3449028. And if we go to page 3, we'll see she is talking about the patient that we've been discussing, but again, I'm looking at this as a broader issue. So she says in paragraph 2.5, in addressing witness W0007's concerns relating to a time delay between having a positive antibody test for HCV in 1992 and not being informed about a result until 1995, it may be helpful to explain the development of antibody testing and PCR testing in that period. Staff from the regional virology laboratories within the Trust have advised that with respect to testing for HCV, the first antibody assays were available from 1992. However, HCV antibody positive result only identifies that a patient has had exposure to HCV, either via a past or current infection, and is unable to determine whether a patient is currently infected or not. PCR confirmatory assays to detect viremia active infection were not routinely available in the early 1990s and were then only used in a research context. At this time, samples were sent to Edinburgh University or to Birmingham Public Health Laboratory for HCV PCR testing. The team advised that from the mid-90s, some HCV PCR tests were performed in the RVL Belfast. However, none of the assays at this time were commercial assays, and all these assays had intermittent sensitivity and specificity problems. And then she says, until the mid-2000s, HCV PCR testing in the RVL was done in a variable way, either locally or sent away or both.
I think we're missing that on the screen.
Oh, I'm sorry. Could we go to the bottom of the page, please, Sally? And given issues with sensitivity and specificity, the clinical advice from the virology team was to look at the pattern of PCR results over a period of time, rather than absolutely rely on any one result. And then she says, the Trust, having reviewed the medical records of witness W0007, can confirm that a sample was taken from the witness in 1991 for HCV antibody testing, and the result was issued to the Trust in 1992, indicating that the witness was hepatitis C antibody positive. Then she says, and she says those results are contained in the clinical notes. In 2.10, she says the first PCR test result from the RVL in the medical record is from December 1995. The receipt of this first positive PCR result is the first point where it can be said that the witness had an HCV infection. This is because the previous antibody test results could only identify exposure to HCV. And then she refers to a letter I don't think we need to refer to it, a letter written by you to the GP, and then says, however, once the PCR positive result from the RVL became available, confirming that witness W0007 had a current HCV infection, his parents were informed accordingly. Now, it might be said that the explanation there being given for this delay in informing the patient and his parents there is different from the explanation you've given, Dr. Dempsey. You say you've accepted he should have been told in 1992. You thought you had, but you couldn't find proof of it, and so you did it again in 1995. Ms. Leonard appears to be suggesting that it's something to do with the difference between the testing available in 1992 and the PCR test reliability.
Well, this is to you, Ms. Richards. At the moment, I have difficulty in seeing how Ms. Leonard can be right about that, because she gives the date of the first PCR test, assuming that she's accurate, as being December 1995. The letter to the GP is May 1995.
The letter to the parents is May 1995.
Parents is May 1995. So that's at a time when there wasn't a PCR test, and it would appear that the letter to the GP is June 1995. So there are letters written without the need for there to be a PCR test first.
Yes, I entirely see that, sir. And it's really because Dr. Dempsey, who was the clinician involved, has given us his own recollection of what the position was. I wanted to just explore with him whether he had any observations to make upon what Miss Leonard appears to be suggesting.
Yes, well, at the moment, as I say, I can't see how she's giving an explanation for what happened, which is the explanation at the moment that I have is from Dr. Dempsey.
So any observations upon what Miss Leonard says, Dr. Dempsey?
Well, I think, an antibody test is sufficient, points strongly to active infection. And I think on the basis of a positive antibody test, you would talk to parents and explain the situation to them. And indeed, that's what I did with the majority of these patients in 1991. I spoke to them on the results of the antibody test. The confirmatory test, or PCR, was developed and introduced later on as confirmation of the antibody test. The antibody test strongly points to a presumptive diagnosis of active infection, and that was borne out in most cases when the PCR tests were subsequently done, when the PCR tests subsequently became available. So I would have thought that it was perfectly right, proper and reasonable to speak to the parents on the basis of an antibody test, and that's what I did. It's interesting you say that the Trust really, the virology lab only introduced antibody testing in 1992 from Miss Leonard's letter. So that sample that was dated sometime in 1991 and was untested, and the result only reported back in 1992, may have been submitted and retained and done when the test became available. It remains my memory, however, that I think tests were batched and sent, I think, to London, and early results returned from London, and the test from the virology is merely repeating a test that was done in London. And that's how my memory serves me on this.
So would it be right to understand then, we can take that down, thank you, that as a matter of principle, your approach would be those test results, whether it's 1991, 1992, if they're positive, you should be telling the parents, patients in relation to that, and your recollection is that is what was done, or not necessarily in the case we've been looking at.
That's right. Yes, that's right.
Can I then just ask you a handful of questions about the arrangements for the care and treatment of the patients who had tested positive for hepatitis C? As I understand your statement, there was no paediatric hepatologist to whom you could make a local referral. Is that right?
No paediatric hepatologist in Belfast, no.
Do you know whether funding had been sought for one by the board, or application made to the board?
I suspect they were looking for a paediatric gastroenterologist who would have overseen paediatric hepatology. I expect a request had been made, because I think certainly by 2000 one had been appointed. So in the later 90s, I think there was a paediatric gastroenterologist who would have provided that sort of advice and help.
Did you give consideration to referring the patients who tested positive to hepatologists elsewhere in the United Kingdom?
No, because I didn't think their liver function was sufficiently abnormal, or the general findings are sufficiently abnormal to warrant it. Although certainly referral to a hepatologist in England would have allowed the hepatologist to talk at length to the parents about the problem. So from a counselling point of view, it might have been helpful, but I didn't think they were in need of urgent medical intervention, in my estimation.
Was there any form of support or counselling that was available to parents at this time in the 1990s?
Well, we did have a social worker and we may have had two social workers at that time, so there would have been some time available to assist with counselling, but not a psychologist, no.
You, I think, didn't arrange for the treatment of your patients with interferon or interferon ribavirin, but took the decision that treatment should await their transfer to the adult centre. Why was that, and was there not a risk of ongoing liver damage in the intervening period?
Well, as far as I could see, they were well when I was counselling them. The liver disease associated with non-A, non-B hepatitis generally developed over a period of roughly 2 decades. There was interferon treatment, which was licensed actually in November 1994. It was toxic, unpleasant, and not very effective. Results, permanent elimination of virus. Test results of studies were as low as 12% of the patient population treated with interferon alone sustained a continuing response. So there were prospects at that time that the interferon ribavirin combination would provide better results. There were clinical trials ongoing at that time, and I felt that it was best to await the results of those clinical trials, which held out the hope for better results, and that's what I explained to the parents. By the time those results came through, we got to 1996, and most of the patients were ready for referral, or had reached the age for referral to the adult unit, who had more experience in treating hepatitis C than I had, and I thought it was probably preferable that the experienced team should undertake the work of delivering what was a fairly complex treatment with a lot of side effects and a lot of unpleasantness associated with it. So that was my advice at the time.
And your statement suggests that by 1998, the last of your paediatric patients with hepatitis C transferred to the adult centre.
Yes, I think 1997 they'd all have gone.
In the intervening period prior to transfer to the adult centre, what form of ongoing monitoring or review was there of the hepatitis C patients?
Well, we'd see them about every 4 months and do their liver function test, check their general health, and do physical examination. We didn't do scans.
And why was that? Why no scans?
Well, progression to cirrhosis would be a focal problem, and I thought at this stage in the disease it was unlikely they were going to pick up focal abnormalities. It was more a diffuse problem.
And can you recall what kind of advice and information was given to the patients or their parents about the condition and what they should expect?
Well, I was fairly forthright at the beginning, and I said that this was probably a progressive disease over roughly 2 decades. There was no treatment initially. There was hope that treatment might become available. They understood it was serious and quite probably progressive, and that over time serious liver disease might result in consequence of their infection. So that was the advice I gave them.
The inquiry has seen evidence in relation to patients at the adult centre of hepatitis C tests being done in 1990, 1991, but not being communicated to, the results not being communicated to the patients potentially for a number of years until perhaps 2 or 3 years later. Did you ever have any discussions with Dr. Main about that, or did she ever say to you anything about a policy or practice of not communicating the early hepatitis C results to her patients?
No, she never communicated any such feeling. In fact, when she let me know the results of the batch tests that were sent away in 1991, she suggested that I should get on with approaching the parents and letting them know the result. That's my memory of the discussion I had with her way back in 1991.
Can I then just ask you briefly about the VCJD notification exercises with which you were involved? You've described in your statement, I think, involvement with 2 such exercises, one in 2001, one in 2004. We've got various documents relating to them, and I think we've looked at them in some of them in earlier inquiry hearings. Could you just tell us, and if you need to go to the documents to prompt your memory, we'll do so, but could you tell us your recollection of the discussions you and Dr. Julia Anderson had about the approach that you should take to notifying patients and why you took the approach that you did?
The first notification in 2001, at that time we had lengthy discussions between ourselves. There was a suggestion from some quarters of the UK HCDO that we should write to parents, patients' parents, and give them the option of finding out if they had been exposed to an implicated batch or not. We chose in Belfast in conjunction with a number of other centres in the UK to directly approach those patients who had been exposed to an implicated batch, talk to their parents and inform them of that result. In 2004, the approach changed, and we had, I think most people at that time adopted the approach of writing to all the patients who had plasma products between certain dates, I've forgotten exactly the dates, notifying them of the risks that might accrue or could possibly accrue around exposure to an implicated batch derived from someone who went on to develop VCJD. And we invited them to write back to us and choose to determine whether or not they wished to know whether they had been exposed. I wrote quite a number. I wrote, I think, to 19 patients. I think 17 replied, and I think all of the 17 wanted to know if their children had been exposed to a batch, including the one or two who had been exposed to a batch, and the many others who hadn't been exposed to a batch. So we wrote the appropriate letters to each of them, and we saw the patients who had been exposed to an implicated batch, and we talked to the parents and counseled them. And we invited any of the others who wished to come and talk to us to come up and talk to us. And I think that is a summary of how we approached the problem, both in 2001 and 2004.
And do you recall anything about the response of patients, the impact upon them of this information with all its inherent uncertainties?
Well, I think most of the parents seem to be fairly phlegmatic about it. I mean, how people appear to you in a counselling session doesn't necessarily reflect the turmoil which lies beneath, but from what I could see, most parents took the information fairly phlegmatically, and there weren't any major emotional outbursts in a way, surprisingly, and that's what I found.
And then I just wanted to ask you, lastly, on VCJD, about the public health measures that were implemented. If I pick it up at your statement, Dr. Dempsey, WITM 5560001, and if we could go to page 54, please, Sally. So you say in paragraph 109 onwards, it was decided advice around public health measures would apply to all patients attending the centre who'd been exposed to treatment with blood products. The dental department was informed and a list of patients provided. The list to remain confidential. The dentist concerned to be provided with information around precautionary measures to be taken. Liaison was established with the surgery department in the Children's Hospital. They've been advised of appropriate measures to be taken. Protocols for the care of operative instrumentation have been received. And then arrangements for children requiring surgery were in place for the parents to liaise with the centre prior to surgery and for surgery to be carried out exclusively in the Children's Hospital. Permanent medical staff covering the centre were aware of the list of patients previously treated with blood products. And patients on this list presenting for surgery and coagulation factor cover will be notified to the surgeon concerned. Do you know whether the patients or their parents were told that their details were going to be provided to the dental department and to the surgery department as described there?
But the details weren't referred to the surgery department. The plan was that if a patient presented to the unit and required surgery, to our unit, required surgery, and was on the list, the member staff covering the unit on the night in question or day in question would liaise with the surgeons Relation to the dentists, well, no, I don't think we said to the relatives, we're going to go to the dental department and we're going to advise them. I suppose we were in the habit of advising the dental department anyway about patients who are Hep C positive. Did we tell the patients about that? I think probably we did in discussion. When we talked to the parents who had the implicated batches in the VCJD scenario, I think we told them that precautions would have to be taken in the dental department. And they realized that those precautions would necessitate telling the dentists. So I think they realized that we would be liaising with surgeons and dentists if they came to rely on either specialty for help.
And did you receive any reports, whether from the patients or their parents or from other sources, of negative impacts on children and their treatment, of appointments being deferred or cancelled, or a reluctance to treat, or being pushed to the end of the day and made to feel like a pariah? Did that get reported?
No, not at all. No. The dental department is right beside our outpatient department then, and we had close liaison with the dentists. So when the haemophilia patients came up to the review clinic, they were seen by myself or Dr. Cairns. And then we would liaise with the dentist next door. The patients would go out, wait, and then go in to see the dentist. So we had a very close relationship with the dental department then. And that's how it worked. And there was never any question that they were treated as pariahs or excluded or not treated as they ought to have been.
And then finally, Dr. Dempsey, more broadly, and thinking now as a haematologist more generally, rather than focusing on the haemophilia patients about whose care I've been questioning you, do you recall in the 70s, 80s, 90s, consideration being given more generally to the importance of minimising the use of blood or blood components, avoiding transfusions where unnecessary, not over-transfusing, avoiding single unit top-ups? Do you recall those kind of conversations taking place?
Oh, yes, they did, yes. There was a transfusion committee in the Children's Hospital, or in the Royal Group, which came into existence, I'm not sure if it was the late 90s or 2000s, which took on board that remit. So I think very much that was a topic of conversation.
And prior to the establishment of the Transfusion Committee, do you remember it being a focus of education or training more generally?
Well, I think from way back, I mean, when I was a junior doctor, blood was tended to be transfused, I wouldn't say on a whim, but fairly liberally. And then we come to an age when we were told if a patient needed, and this is an adult practice, if a patient only needed 1 unit of blood, they didn't need the blood at all. So there was a developing, people were developing an idea that blood had to be treated with certain respect, and patients who are exposed to blood have to be exposed on a very good pretext.
So those are the questions I have for Dr. Dempsey. But bearing in mind it's gone past 1 and we need to afford the opportunity to call participants and their legal representatives to suggest any further questions. Could we break for lunch now and then come back with any further questions after lunch?
Yes, well, we'll do that. We'll come back at 2 o'clock. Would that,
yes, that
suit your timetable? 2 o'clock, if you please, Dr. Dempsey. There'll be some further questions. What Council has to do is to liaise with those who are core participants. They aren't, of course, here in the room, and they may have further questions which they would like her to put to you. So that will happen at 2 o'clock.
Thank you.